Dr. Stanley Rockson is the Alan and Tina Neal Professor of Lymphatic Research and Medicine at Stanford University School of Medicine. After earning his medical degree from Duke University School of Medicine, Dr. Rockson completed his internship and residency training in internal medicine at Brigham and Women's Hospital of Harvard Medical School. As a professor of medicine, Dr. Rockson serves concurrently as Stanford's Chief of Consultative Cardiology and the Director of Stanford Center for Lymphatic and Venous Disorders. Dr. Rockson is Editor-in-Chief of Lymphatic Research and Biology and sits on the editorial board of Angiology. Dr. Rockson works closely with the National Institutes of Health in an advisory capacity to advance the agenda for lymphatic research. Ladies and gentlemen, please welcome Dr. Stanley Rockson.
Hello, welcome to my talk on lymphedema diagnosis and management, state-of-the-art, and a look to the future. I am pleased to be given the invitation by the organizers of this conference to talk to you about a topic that I think is very, very important, specifically to cancer survivors, because cancer survivorship represents well over 50% of all of the lymphedema that we see in the United States. For many, lymphedema is a familiar term and a familiar problem, but for others, the terminology and the concept is new. So we'll be going over all of the material that is necessary for you to think about this. I'm going to start showing my slides. Let's start by talking about the lymphatic system. The lymphatic system is part of the circulation, and it's also part of the immune system. Many cancer survivors are familiar with the term lymph because lymph nodes are commonly sampled in making cancer diagnosis, and lymph node areas are often the subject of radiation therapy as well. However, for our purposes, what we want to think about is what the lymphatics do in terms of fluid transport through the body. And as you can see here, this is a tremendous system within the body that at any given time holds about 2 liters of fluid, which is about 40% of the cardiac output. There is about 25 milliliters per minute flowing, milliliters per second flowing through the system. And this system covers about 3,500 kilometers in the human body. So what does the lymphatic system do in health and disease? Most importantly, as we've just said, it's important to help fluid to transit from the space around the cells everywhere in the body back into the circulation, and thereby to maintain fluid balance. In the gastrointestinal tract, which is not really so much a part of today's discussion, the lymphatics are also essential for us to absorb dietary fats. And as I mentioned, the lymphatics are part of the immune system. They represent the ability of the body to carry messages to the immune system from the frontier at which infection and other events occur. And again, without a well-functioning lymphatic system, the immune function cannot be maintained. So lymphedema, simply stated, is the disease condition that occurs when in some region of the body, this circulatory system becomes impaired. And in the setting of cancer, that is typically because lymph nodes have been removed surgically. Perhaps they've been directly involved with cancer, or those lymph nodes have been the subject of radiation therapy and have been secondarily damaged. When the individual develops lymphedema in an arm or a leg or in another region of the body, there are going to be a number of predictable physical effects that will occur over time. There is the accumulation of protein-rich fluid within the tissues, and then in association with this, there is inflammation, there is scarring. The body secondarily deposits fat in the region. As we mentioned, the immune function will be disturbed, at least locally, and secondarily, there will be effect on ligaments and tendons. All of this has predictable outcomes for patients that have been well documented in studies that look at the impact of the presence of lymphedema on quality of life. We know that physical performance can be impaired, and thereby you have loss of work productivity. Often patients with lymphedema feel socially isolated because lymphedema very often has an effect on the overall physical appearance of the individual. This can cause erosion in self-esteem and impairment in body image. And secondarily, then we can have a significant problem with depression or anxiety. So let's put lymphedema in context before we dive deeper. The simplest categorization that we can utilize, we typically talk about primary versus secondary lymphedema. So the lymphedema associated with cancer is a secondary lymphedema. It's acquired presumably because the lymphatic system was normal prior to the cancer and its treatment. Cancer is not the only problem in which we see lymphedema, even the acquired form. It can be from other surgical interventions. That's what the term iatrogenic means, is caused by a doctor. It can be from trauma. It can be from vein disease or infection. Among the cancers that typically cause lymphedema, we know that breast cancer has historically been the greatest percentage of the total lymphedema population related to cancer, but you can see the other common cancers listed here that are capable and often do cause lymphedema as a consequence. I'm just going to mention primary lymphedema briefly because it's not really the subject of today's discussion. Primary lymphedema in itself is a rare disorder. There are only about 50,000 cases against the denominator of the US population. This is in contradistinction to acquired or secondary lymphedema, which is a very common condition. And whether or not your doctor knows about it or talks about it or feels that it is a predictable process within your cancer care, it is indeed quite common. And we think that 5 to 10 million Americans are affected by secondary lymphedema. But primary lymphedema is uncommon. We think it's on a genetic background, and it can occur not just at birth, where we would call it congenital, but the majority of primary lymphedema occurs during puberty and young adulthood, and this represents up to 80% of the cases. So, how do we diagnose lymphedema? Well, most importantly, the diagnosis occurs by physical examination. And one of the things that we're looking for, of course, is the presence of edema or swelling of the limb. But in lymphedema, there are several characteristic attributes, and one of them is the loss of elasticity in the skin as the physical changes occur that are distinct to lymphedema. So here you see an example of, on the left leg, which is the normal leg, what we would call a negative stemmer sign, meaning that we can pick up the skin at the base of the toes easily because the skin is quite elastic, and you can see the superficial anatomy of the structures beneath the skin showing through the skin because the skin is thin and normal. On the right-hand side, you see that the toes have developed a sausage-like deformity with creases at the base of the toes. And I think you can easily imagine that if this physician were attempting to pick up the skin at the base of the right toes, he would be unable to do so. So this is what we call a positive stemmer sign, which is considered to be diagnostic of the presence of lymphedema. Increasingly, of course, we rely upon self-diagnosis, often which is incorrect. We certainly should rely on the physical examination, but if we need to, we do have imaging tests that can be performed to not only determine whether lymphedema is the cause of the problem, but also to classify it, categorize it, and think about potential treatment options. So the gold standard for the lymphedema diagnosis in today's utilization is what's called a radionuclide lymphoscintigram, or lymphoscintigram sometimes is the full name that's applied. So this is an abnormal lymphoscintigram in a woman with lymphedema of the right arm. This is the right arm because of breast cancer treatment. So what's happened here is the examining physician has injected a trace amount of radioactive material into the base of the fingers in the skin on the back of the hand. And this material injected requires uptake by the lymphatic system to travel up to the draining lymph nodes. And on the normal side, you can see that the material has appeared in the lymph nodes of the armpit region, but there is still, at the same time point, no appearance in the remaining lymph nodes on the right side. In addition, you see this very dense staining of the skin along the transit path of the material. And this is because the lymphatic flow is under high pressure, and some of the lymph is being forced back out into the tissues where it stains the skin temporarily for the imaging process. So the presence of this finding, which is called dermal backflow, and the absence of lymph node uptake characterizes lymphedema and makes this a positive examination. We can also use MRI to look at the lymphatics, and we can do this both in the arms and the legs. But also, most importantly, we can see the central lymphatics, which we cannot see with a lymphoscintigram. So here, the MRI has shown us what is called the thoracic duct, which is a little bit like the aorta of the lymphatic system. It's the main channel that takes the final flow of lymph from the body back to the heart. Now, the most recent addition to lymphatic imaging that we have is what is sometimes called near-infrared lymphography, or sometimes we use the name of the imaging material that we use, which is called ICG. But again, we need to inject it into the skin because the lymphatics are a one-way transit system, and we have to be able to image transit from the skin into the lymphatic system and then back into the central circulation. So here you see an example of one of these examinations where the material in the lymph system is actually fluorescent and can be seen under an appropriate wavelength of light. And you can see these lymph channels ascending the leg going up toward the groin area. This is an abnormal study where you see that same attribute of dermal backflow, that staining of the tissue along the route of lymph flow, and not very good delineation of the lymphatic channels themselves. So with all of that, let's talk about how we stage lymphedema. I want to make the point that the International Society for Lymphology, the ISL, has given us a staging mechanism, and we also talk about stage 0. Stage 0 is what we think of as a setting in which we can demonstrate the lymphatics to be abnormal, but there is no edema detectable by clinical examination. So here we have the perfect scenario, we think, for disease containment and potentially prevention by recognizing this. And I will tell you that at least at Stanford, we have an active screening and surveillance program of cancer patients where we perform non-invasive studies, which I'll talk about in a moment, to try to detect stage 0 so that we can try to prevent the development of lymphedema in high-risk patients. As we progress down the clinical staging mechanism, you'll see that what we are going to observe as we go to higher and higher numbers is reduced amounts of detectable fluid and reversibility of that fluid accumulation by elevation, and increasing changes in the tissues themselves, like we saw in that photograph of the foot, where the skin is actually distorted to the point that it cannot be correctly identified as having normal skin characteristics. So let's talk for a moment about stage 0. How do we detect stage 0, at least in my program? Well, we use an approach called bioimpedance spectroscopy. And what this means basically is that if you apply a tiny electrical current to the skin, something that you're not capable of feeling, if you dial down the frequency of that current to a low enough level, it cannot enter the cells and will travel through the fluid around the cells. And the rate of fluid transit is going to be proportional to the amount of fluid that's there. The more fluid you have in the extracellular space, the more rapidly the current will travel. And consequently, we can quantitate that by using a simple device and detect if there is an expansion of the fluid volume in that extracellular space. So when that value becomes abnormal, either in relationship to pre-treatment values or to baseline assessments after treatment intervention for cancer, we can detect the advent of subclinical lymphedema that will be very responsive to treatment and potentially can be reversed, and lymphedema can potentially be eliminated. If we're not able to make that detection or we're unsuccessful, we eventually progress into what you could call stage 1, in this case, stage 1 lymphedema. What I've done to this limb is take my examining finger and put some firm pressure on the tissues to basically push the fluid out of the way temporarily. So I leave what's called a pit. And this pitting edema is characteristic of all edema, but in the case of lymphedema, over time, it disappears, and the excess volume that used to be displaceable fluid becomes overgrowth of tissue. So here you can see in another patient, I've attempted the same maneuver. All I've succeeded at doing is making the skin under my examining finger a little redder temporarily, but nothing's moving. And that's because there has come an abnormality in this limb where there is an overgrowth of cells, there is deposition of scar tissue, there is accumulation of protein, there is loss of elasticity of the skin, and all of that means that this edema is no longer reversible in the standard fashion of elevating the limb or applying external compression. So let me show you what that looks like by MRI. I'm showing you the cut edge of a grapefruit as a point of comparison, but this is an MRI of a lymphedema limb. It's a leg, and we're looking at the level of the thigh. So this is the femur bone, or the large bone that runs through the thigh. And what you see here is what looks like the cut edge of the grapefruit, the rind, is actually the patient's skin that has thickened to about 20 times or 30 times what it would normally be. We can hardly see it on a normal limb, but all of that skin thickening is a very direct attribute of lymphedema. The other thing that we see in lymphedema, and this is a post-mortem specimen of a patient who died 15 years after breast cancer treatment. The death was not from breast cancer, but from other causes. But what you'll see is, in addition to the very thickened skin, which is delineated by the 2 red arrows, and similar to what you saw in the MRI, look at this tremendous overgrowth of the subcutaneous fat. This layer should be perhaps as thick as where my arrow is moving right here, but instead it's expanded 30 to 50 times. And this is a predictable and almost irrevocable attribute of chronic lymphedema that is eventually what happens, particularly in poorly treated lymphedema, but even when we treat properly, this is sometimes unavoidable and represents a big component of what we think of as the irreversible or the traditionally irreversible phase of lymphedema. So with that in mind, now you understand a little bit about why lymphedema is such a big problem and why it creates such quality of life issues for individuals. How do we treat it? Well, the core of treatment is called complete decongestive physiotherapy. This treatment is accomplished by a highly trained therapist. It can be a physical therapist, occupational therapist, it can be a nurse, but it represents a suite of interventions that include direct physical stimulation of the contraction of the lymphatics by physical manipulation of the skin by the therapist. There is often application of multi-layer bandaging that has to be done on a repetitive basis. And this creates a compartment in which the lymphatic action can be augmented over longer periods of time while the patient remains physically active during exercise. And we typically undertake a treatment strategy of 10 to 15 or 20 consecutive sessions like this to get the limb down to its attainable smallest volume, which on average is about a reduction of 50% of the excess volume that's present when we start treatment. It is only at that point that we apply a garment, and many of you are familiar with the fact that lymphedema patients have to wear a compression sleeve or stocking. A common mistake that I see in overall medical practice is that many physicians who acknowledge that a lymphedema limb needs compression with a garment, apply the garment before the decongestive treatment is applied. A garment will not typically make the limb smaller. The purpose of the garment is to keep it from getting larger. So once we get the limb down to its smallest attainable size, we then want to use a garment to preserve that effect and keep the limb from swelling again. There is unfortunately no cure for lymphedema, at least under current clinical practice, but once we attain a level of control, we want to maintain it. For some patients, it is difficult or impossible to pull a tight elastic stocking onto the leg. So we have these alternate types of garments that apply pressure by surrounding the leg through Velcro attachments. They apply exactly the same amount of pressure. They work in an analogous fashion, and this represents a very nice alternative for many patients. We sometimes use garments at night. In my practice, this represents about 10% or less of my patient population. And generally, because the individual is in the horizontal position during sleep and gravity is not playing a role, we generally don't see a lot of additional fluid accumulation at night, so that the next morning the patient can put the sleeve or stocking back on again. But if that's an issue, that the limb swells during the night, then we have garments that can be worn a little bit more comfortably for nighttime use. We often also rely upon various forms of dynamic compression. So once the patient has finished the intervention with the physical therapist or whoever is giving the active therapy, there are these devices that can be prescribed for home use, so the patient can consider can continue self-treatment on a daily or several times per week basis, utilizing a device that typically an insurance company such as Medicare or commercial payers will purchase for the individual. And these come in a variety of configurations with a variety of capabilities. Most recently, I've been involved in the development of a non-pneumatic compression device that allows for dynamic utilization. The patient actually can put this device on and off easily and can wear it during active activities of daily living or during exercise. And we get the synergism between the device applying external compression as well as the impact of exercise itself on lymphatic function. This is how the internal mechanism of the device works. So it provides rhythmic contraction that passively stimulates the lymphatics. And if this is being worn during activity from the inside, the lymphatics are also being actively stimulated and drained through the contraction of the muscles underneath. When we do this, we can demonstrate that lymphatic flow is actually augmented by using that infrared imaging technique that I demonstrated to you earlier. So with all of these modalities that I've described to date, the thought is the earlier that we can identify lymphedema, even pre-clinical, if we're lucky enough to do that, and we dial in these treatments, we can stabilize the limb and get it to a minimal limb volume and keep it from progressing to those worsening stages where there is little that historically we're able to do. Many of you might be aware of the fact that we now have a growing armamentarium of surgical options for lymphedema as well. These are elective and they're not necessarily for everyone, and they have pluses and minuses associated with them. We have two broad categories. One is what we could call debulking, which is to get the limb down to a more attainable and functionally relevant size. And the second is microsurgical reconstruction of the lymphatics themselves. So for debulking, what we do primarily is to address that dramatic overgrowth of fat that I showed you in the postmortem specimen. And we perform what is called suction-assisted lipectomy. This is a modified type of liposuction intervention that's performed under general anesthesia, and it has been modified specifically to deal with the problems related to lymphedema. This is typically what would be removed from the patient after a successful surgery. This is about 2 liters of fat that have been removed from the limb, reducing the limb size back to normal. And what you see is what we typically are able to accomplish, which is maintenance of a normal size limb over long periods of time. This individual, when this picture was taken, was 12 years out from the surgery that I just showed you. And you can see that she has been able to maintain her limb volume at normal. So it's actually, if anything, a little bit smaller than the originally normal size limb, and this requires only aggressive use of a compression garment. Now, the downside of this therapy is the patient becomes intensely compression dependent, both to achieve the result and to maintain the result. And an individual has to be able to be fully compliant with garment use over extended periods of time for this to work. But what we can provide for the patient is a restoration to a normal size limb. Now, for microsurgical reconstruction, which basically is surgery that is performed under a surgical microscope, we're working on vessels that are tiny, tiny, tiny. The surgical suture is so thin that you can barely see it with the naked eye because we're working on these tiny structures within the body. But we rely on that infrared imaging technique that I showed you to stage the lymphedema and to determine which of the microsurgical techniques might be applied in the particular case of the individual. So as you see the progression from normal toward the most dramatically abnormal, you can see that once we leave stage 2, we're no longer really seeing well-defined lymphatic channels, and what we're seeing primarily is worsening dermal backflow. So these categories of patients are candidates for what we call lymphaticovenous anastomosis, or LVA, where we bypass the lymph flow from the lymph channels into the nearby veins. And here we have to do a technique that is called autologous or vascularized lymph node transfer. So I'm going to talk a little bit about both of those. Lymphovenous anastomosis, as I mentioned, is a way of rerouting lymph fluid out of the limb by not relying on lymph flow, but instead relying on outflow from the veins. So you see it schematically illustrated here. In order to do this, we need to be able to identify intact lymphatic channels that still carry lymph and that are surgically identifiable. And there need to be normal venous structures adjacent to which the bypass can be provided. So this is actually a relatively simple surgery from a surgical standpoint, in the sense that it takes perhaps 1 or 2 hours. As I said, it's performed under a surgical microscope, but it's an outpatient surgery with a fairly rapid recovery. If the patient is in one of those latter stages of the lymphedema and is no longer a candidate for LVA, what we typically think about is taking normal lymph tissue from a normal part of the body and placing it into the limb that's involved. There are various theories about how this surgery works. My theory, and the one I think that is most commonly held, is that the normal healthy tissue actually orchestrates lymphatic repair and the growth of new lymphatic vessels and structures to help with the existing lymph drainage. This surgery is a very complex surgery. It takes many hours to accomplish under general anesthesia. It does require 3 to 4 nights stay in the hospital and has about a 3-week recovery at home, where the limb that's been operated on needs to be kept elevated and not used until the complete surgical healing has occurred. What we're trying to prevent is swelling of the graft itself, because that will eliminate its function and make it an unsuccessful procedure. So for these microsurgical techniques, I would say the likelihood that the patient will experience some improvement, which could be a little to a lot, is about 80%. So there is a 20% non-response rate to the surgery, which has to be borne in mind for anybody who chooses to do this surgery. And the spectrum of response is quite broad. Some patients achieve basically the returning to stage 0. That's, I would say, uncommon, but feasible. And at the other end of the spectrum, the response might be really quite modest. So this is a very personal decision about whether to pursue this, and it's not, should not be considered as cure. So let me finish by talking about my vision for the future. Again, let me remind you that what we're dealing with in the natural history of lymphedema is the progression from lots of fluid, which can be moved around physically. Sometimes there are even medications that can help to eliminate it. But over the passage of time and relatively rapidly, we progress to these latter stages of lymphedema where, unfortunately, no impact on fluid is going to impact the limb substantially. And basically, this has historically been called the irreversible phase of lymphedema. Well, about 25 years ago, I became very frustrated by the notion that we had nothing to offer for this component of lymphedema, coupled with the fact that, in my view, as a cardiologist and an internist, I would like to think of lymphedema as a typical chronic disease in an adult, which typically we treat with medications. So I launched into a investigative approach to try to identify drugs that might have an impact on this aspect of the disease. Now, what I want to explain is that most of the business end of lymphedema is in the layer of the skin that we call the dermis. So on the left-hand side, you're looking at a cross-section under the microscope of normal human skin. And this purple zone and then down to the horizontal line that I've drawn, this is all the dermis. Below this is what's called the hypodermis and eventually gets into the muscular underlayer of the arm or the leg. But most of the lymphatics live in this layer of the skin, and this is the part of the limb that gets affected when lymphedema occurs. Here's a skin biopsy from a patient with lymphedema, and in addition to seeing these hugely dilated lymph channels, which are not present in the normal skin, you can see that the dermis has become so thick that it doesn't even fit on the slide anymore. This is all dermis, and actually the dermis extends even beyond where I've taken the picture. So what we learned in our early years of working with this is that when the lymph system doesn't operate well, and because we both impair immune function and have this accumulation of fluid, we set up a circumstance in which we get chronic inflammation in the skin. This may couple with recurrent infection, which is very common in lymphedema, and eventually we get to this stage of progressive scarring and deposition of fat. And we were able to elaborate the notion that this chronic inflammation is really at the core of everything else that happens. So let me show you, and I've skipped a lot of steps here about how we made these discoveries, but we eventually discovered the molecular signaling pathway that leads to the inflammation that in turn leads to the lymphedema. And we've worked extensively in a mouse model of lymphedema where we create lymphedema in the mouse tail and then can treat it and learn how our treatments are effective. I'm not going to show you the saline control for the drug because it basically doesn't show anything, but I'm going to you'll have to trust me that we don't see anything comparable in that image. But in the interest of time, I'm going to show you this movie, which is that fluorescent imaging technique in the mouse tail. This is the lymphedema portion of the tail. This is where the surgery was performed. And when we treat this animal with medication to reverse the lymphedema, you can see we are restoring flow in the lymph channels that take the lymph back to the body. We do not see that in the saline control animal. And this reflects the impact of a drug that we delivered systemically to the mouse to heal the lymphedema. The lymphedema goes away, and without doing anything directly to the lymph channels, we restore flow through them and, in a sense, reverse lymphedema. So this is a very exciting finding. And based on these findings and others, we were able to progress to a pilot clinical trial in human lymphedema. This was arm and leg lymphedema. The majority of these patients were cancer survivors, but there were also patients with primary lymphedema in the study. Let me show you a dramatic example of what we've been able to accomplish with our work to date. So this is a patient who had lymphedema of the left leg on the basis of cancer treatment for a gynecologic malignancy. She was an intensive care unit nurse who had to stop working because she could no longer bear weight on this limb consistently to work in the hospital. She entered one of our clinical trials. She was treated for 6 months with effectively the same drug that I showed you in the mouse tail a moment ago. And she was treated for 6 months, and the trial only lasted 6 months. So at the end of that time, she had to stop taking the drug. And this is what her leg looked like 18 months later after she stopped the drug. And you can see that she's been able to maintain its normal size just by wearing a simple compression garment. She went back to school, got a master's degree, has returned to nursing, and her life has been turned around. Now, just like the surgery, there have been a spectrum of responses, and this is a dramatically favorable response, but a very encouraging one. What I'd like to tell everybody attending this meeting is that we are actively involved in the latest iteration of this work, and we're currently undertaking this trial where we're actively enrolling patients at Stanford in a trial, in this case, looking at arm lymphedema. Now, I always hasten to tell an audience of patients that it's not that we're just interested in arm lymphedema, but because arm lymphedema patients are more similar to one another than our leg patients, both in terms of severity and causation, it allows us to reach endpoints in the trials with much, much smaller numbers of subjects for statistical reasons. And what we want to do is get to the endpoint as quickly as we can. So this is an arm lymphedema patient that is meant to be generalizable to all lymphedema once we make these initial observations. We are using a new drug that is highly targeted to the area that the molecular pathway that we're interested in. So much more targeted than the drug that I showed you either in that leg or in the mouse that preceded it. The drug is called acebilistat. This is a phase 2 study being performed by the FDA, under the auspices of the FDA, I should say, carrying forward my research. It is on an investigational drug that has never previously been commercially available, but has been used in about 500 human subjects in a variety of contexts. And we know it to be very safe, with no identifiable serious toxicity. And as I said, it's a highly targeted drug to the molecular pathway that we're interested in. This is what we call an open label study. So this does not involve placebo control, and we're using each subject as his or her own control in the study. Our primary endpoint is dermal ultrasound. So I've already shown you what the dermis looks like under the microscope. We can actually see the dermis by applying a probe directly to the surface of the skin. And you can see these markers are showing you what portion of the ultrasound image is the dermis. And we're looking for changes in the thickness of the dermis prior to treatment as opposed to after the patient is observed for 9 months of treatment with the drug. And we'll be doing this at 3 sites in the lymphedema arm and 3 sites in the normal arm, and then we'll be able to detect what happened to the tissues with treatment. So dermal thickness, we'll add the 3 measurements on each arm to come up with an aggregate score. So this is just to let you know that this is a study of lymphedema in a single arm of stage 2 lymphedema, and it will be for in patients who've had the lymphedema for at least 6 months. If the patient has had prior surgery of the type that I've talked about and it's considered unsuccessful by the patient and wants to participate, they have to be at least 1 year out from that prior surgery. Of course, they have to be able to participate knowledgeably and willingly as a subject in a human clinical trial. If they have physical therapy for lymphedema, it has to be completed at least 8 weeks prior to screening for enrollment in our study. And we will ask everyone to maintain everything they're doing for the lymphedema arm throughout the 9 months that they also take the drug. we're not going to enroll anybody who's planning to have a surgical intervention during the 9 months that we would otherwise be treating them. We can't work with anybody who has any other reason that could potentially worsen or aggravate the swelling of the limb. All patients will receive active drug. As I said, there is no randomization to placebo. We see patients over 4 study visits at 3-month intervals over a 9-month total participation. All of you theoretically are part of the Bay Area Cancer Connection, so you are local, and theoretically anybody who would like to participate would not have a barrier to coming to Stanford. But we do actually see patients and already have patients who are coming from the East Coast and other parts of the US to participate in this. It is a non-invasive study. Everything we do is non-invasive. The most invasive thing we do is to draw blood for safety monitoring and for some research purposes. I'm going to leave the slide up for just a moment, or I can ask perhaps the organizers can distribute this information if there is a way to do this. But these are my 2 study coordinators, Shane and George, and anybody who is interested in participating in this study. If you think you might fit into the criteria, you don't have to be absolutely certain. We'll figure that out with you. Please contact Shane or George, and we will undertake the pre-screening process with you and would encourage you to participate if you're at all interested. So I'm going to conclude by saying, or maybe repeat what I've said already, which is that lymphedema is a common problem, particularly in cancer survivors. In some categories of cancer, we think the incidence might climb up as high as 50% or higher. In breast cancer, it's between 15 and 30%. In gynecologic malignancies, it's 30 to 40%. In melanoma, it's in a similar range. And for many of the other cancers, it's somewhere between 20 and 50%, 50% of head and neck cancers. As I've already told you, this is a process that tends to progress, particularly without treatment, but sometimes even in the face of conservative treatments. We have surgical options, but they are limited in their efficacy and the ability to perform them in individual subjects. And I've shared with you that the presence of lymphedema, treated or untreated, has the potential for substantial consequences and impact on quality of life. So that's all kind of on the negative side, but on the positive side, we've been extraordinarily encouraged by what we've been able to accomplish in the laboratory, and honestly getting from a concept that emerged in 2005 in my mind to the point that we're giving drugs to patients is a really rapid trajectory. And within the next 2 to 5 years, we might actually see the availability of ace-bilostat or a similar drug as one that would be available for the chronic treatment of lymphedema. So I like to think that anything is possible. We just have to be partners in the process and make it happen. So with that, I'm going to conclude my formal remarks, and thank you all for your attention. And I'm happy to entertain any questions that might come up.
Great. Thank you so very much, Dr. Rockson, for that highly informative talk. I know I learned so much, and I hope that our audience did as well. Thank you for contributing to the research on this very important topic, and for leaving us with that sense of hope at the end of it as well. I appreciate that. So a reminder to the audience to send in your questions. I'll start by asking a few. We do have some time. So does the risk of developing lymphedema ever end for cancer survivors, or are they more likely to develop lymphedema shortly after treatment, or is it something they always need to be aware of?
That's a great question. So there actually is a fairly predictable time course for the development of lymphedema in relationship to the initial injury. In this case, it's cancer treatment. The bad news is cancer risk never disappears. I'm sorry, said that wrong. Lymphedema risk never completely disappears, but fortunately, it recedes to very low levels over time. So we think, let's talk about the example of breast cancer, where we might say, for the sake of argument, out of 100 women, 25 will eventually develop lymphedema. Men as well, although breast cancer is much less common in men. So of those 25 patients who will develop lymphedema, 95% of them, so about 20, will develop the lymphedema within the first 2 years following the index injury, which means completion of surgery and radiation therapy. Chemotherapy plays a very small role, so we don't really tend to think of it. But let's say the clock starts ticking during treatment and becomes actively ticking at the end of radiation therapy. For the next 24 months is when we have the highest surveillance, because in a way of thinking about it retrospectively, what's likely to happen is going to happen with a relatively small stimulus. And so if it's going to happen, it's going to happen on the front end. That last 5%, which is going to represent, about 1 or 2 patients out of that mix, or 3 or 4, is going to be smeared out over the rest of life. And so obviously, a 2%, 1% chance of developing lymphedema is very small, but the surveillance can drop down to very low levels. The protective mechanisms need to be kept in place so that even that small percentage of risk can be avoided.
Okay, thank you. And you mentioned during your talk that you screen people for lymphedema at your clinic. Is that something that all cancer survivors should expect to be screened for? And if so, by which doctor?
Well, that's, again, a great question. I would love to say that the answer is yes, everybody should expect to have that happen. The sad fact, unfortunately, is that in many centers, the imperative for lymphedema surveillance is not felt, A. B, the technology is pretty specific, and I would say, to my area, to my awareness, in the Bay Area, the only medical center that has the appropriate bioimpedance technology is Stanford. So if patients are receiving cancer care in otherwise the many excellent hospitals and centers around the Bay Area, they can't really expect to have this form of surveillance. Now, there are simpler forms of surveillance, which is, for example, measuring the circumference of the limb at intervals to be sure that it's not enlarged compared to the contralateral limb. The problem is, once you start to see physical evidence of swelling, you're already in stage 1, and already the reversibility is significantly hampered. There is another technology that exists in theory, which is called pyrometry, which has to do with using external photographic techniques to reconstruct the limb and detect very, very subtle changes in edema, which would still be, technically speaking, stage 0. But to my knowledge, there isn't any pyrometry available in the Bay Area either. So I'm hoping this technology will spread. The way we do it currently, and the easiest, it's a very simple technique. We actually do the bioimpedance by having the patient step on what looks like a medical scale with side rails, and by holding the side rails and having the feet in contact with the base, the pedestal, the machine actually measures the bioimpedance automatically. So it's a very, very simple technique. It takes less than 5 minutes, but anybody who wants surveillance of this type is going to have to contact my clinic, and we'll have to have them might be a 45-minute drive for a 5-minute test. But that's the current answer.
Okay, well, thank you. I do hope that technology spreads and makes it possible for more people to be screened.
I will say one other barrier that exists is that, unfortunately, not all third-party payers acknowledge this as a meaningful intervention. So there are some carriers who deny this, and some patients who we deal with choose to undertake out-of-pocket expense because they do want the benefit. But anybody who's looking into this should be aware that if they choose to come to us, we can't guarantee that it will be covered until we go look at the insurance policy.
Sure, that's an important reminder to always check with your insurance. Unfortunately, we're running out of time. I do want to fit in one last question that we get quite often, which is there any merit to preventatively wearing a compression sleeve, especially during activities like flying, for example?
The answer is likely yes, but I also must be very quick to say there have been no definitive studies to actually prove this benefit. So what are the high-risk activities, and how do we come up with strategies to deal with this? Well, what we know is from retrospective analysis of patient populations, it is very often cited that recent air travel seems to be a provoker of the appearance of lymphedema. That's not to say air travel causes lymphedema, but if you're at risk, it can happen. And the mechanism would be that when we travel in a commercial carrier, we're actually at 7,000 feet elevation. And for anybody who's carried, toiletries into the cabin of the plane, when you get to your hotel, it looks like people have been messing with things because that change in pressure causes fluid shifts. And that's what happens in the body. And many of us have the experience of taking off shoes in a plane and then having the shoes feel tight when we try to put them back on again. It's because fluid shifts into the interstitial compartment temporarily. If the lymphatic system is deranged and it's not able to handle that excess fluid load effectively, that might be what pushes it over the edge into this vicious cycle that becomes lymphedema. So by inference, we say, well, if you wear a compression sleeve and you prevent that fluid accumulation in that limb, you're going to reduce the likelihood that something bad will happen. And it makes sense, but it's just never been proven. So air travel is one. Travel to high altitude would be another. And that would be, we think, maybe a threshold of about 5,000 feet elevation. A third would be strenuous physical activity with the limb at risk, because with activity comes increase in blood flow. With increase in blood flow comes greater fluid filtration from the circulation into the tissues. Again, same sort of vicious cycle that can be set up. So wearing it during those activities makes sense. Elevated temperatures might be another one, but it's really a little hard to do that, particularly if the elevated temperature of something like a hot tub or a bath or a shower. So we don't typically recommend it. I will say that one of the activities that's kind of absolutely contraindicated if you're at risk for lymphedema is exposure to a sauna, because at those temperatures, it's been demonstrated to be a very high risk activity that is avoidable and you can't prevent the effect of a sauna by even wearing a sleeve, and wouldn't want to probably in any event.
Okay, thank you very much. That's important information for us to know. With that, we're going to have to say goodbye, but thank you again. And we wish you and your cute dog back there a wonderful day.
Decided to make an appearance. Thank you so much for the invitation. I appreciate it.
Thanks again.
Okay, bye-bye. Thank you, everyone. Bye-bye.